Hi, thank you all for your presence here. You're the less resistant ones. I'm Joana Gameiro, I'm a nephrology resident from Lisbon, and I'm here to present end-stage vascular access failure, one problem, which solution? As we all know, dialysis vascular access failure affects many dialysis patients, and it can culminate in what is called end-stage vascular access failure, which is a complex problem for the nephrologist to solve. So what we wanted with this abstract was to review our experience in handling these situations. We did a patient review of all patients that were admitted to our department between January 2006 and December 2015, and were diagnosed with end-stage vascular access failure, which was defined as the impossibility to insert a central venous catheter in a large vessel due to stenosis or thrombosis of these vessels as documented by CT angiogram or angiography. So in this 10-year period, we diagnosed 16 patients with end-stage vascular access failure. There was no difference between male or female patients, predominance of Caucasian patients. Their mean age at the beginning of renal replacement therapy was 47 years old, and the initial choice of RRT in all of these patients was hemodialysis, and they had been on dialysis for approximately 6.5 years before being diagnosed with end-stage vascular access failure. Our mean follow-up was 32 months. So of these 16 patients diagnosed with end-stage vascular access failure, 9 patients had criteria to initiate peritoneal dialysis, and the other 7 patients remained on hemodialysis with these less resource vascular accesses that were in 5 patients an insertion of a right atrium catheter, and in 2 patients a catheter in the inferior vena cava. Of the 9 patients that were transferred to peritoneal dialysis, 1 patient died after 3 years. On the last follow-up, we only have now 2 patients that still remain on peritoneal dialysis. 2 other patients were transplanted, and the other 4 patients had to be transferred back to hemodialysis with less resource vascular accesses. We have 1 patient with an upper arm graft that we include in this group because it was a graft that was only possible to insert after many angioplasties. It's a patient that had a stenosis of the innominate vein of the cephalic branch, and even after the graft was implanted, needed another angioplasty on the humeral artery because it was too small to supply the graft. Another patient, and this was only last year, so we have a small follow-up of this patient, was transferred back to hemodialysis with the insertion of an inferior vena cava catheter, and the other 2 patients died shortly after, one with a leg graft and one with the right atrium catheter. Of the 5 patients who had an intraatrial catheter, 2 patients died in the postoperative period. 1 patient, after multiple reinterventions due to catheter dysfunction, was placed with a Hero device while already on the super urgent transplant list, and in the following month was actually transplanted, and this was late last year. Another patient, due to hemothorax, was transferred to peritoneal dialysis, and this other patient, after an initial year with many episodes of catheter dysfunction and multiple reintervention, now has a 5-year follow-up with the right atrium catheter and has had 0 infections related to this catheter. And of the 2 patients with the inferior vena cava catheter, due to catheter failure, had to be later transferred to peritoneal dialysis and died on the postoperative period due to infection. To summarize, of these 16 patients who were diagnosed with end-stage vascular access failure, at least 11 of them needed multiple reinterventions and needed rotation through different renal replacement therapies in order to allow for their survival. And on the last follow-up, we have 3 patients on peritoneal dialysis, 3 patients on hemodialysis with these less resource vascular accesses, 3 patients who were transplanted, and we have a 44% of mortality in these patients, with only 2 patients dying after the first year. So to conclude, end-stage vascular access failure is associated with increased mortality, with the majority of these patients dying within the first year after this diagnosis. It was the rotation through different renal replacement therapies that allowed for the survival of most patients. Peritoneal dialysis was an option in 12 of these patients at some moment during their disease, allowing for the survival on this technique or at a transition to another technique. And vascular patrimony monitoring and preservation is crucial to dialytic technique and patient survival, as we all know. And in this extreme situation of end-stage vascular access failure, the solution we have is to formulate an individualized strategy that derives from a multidisciplinary approach from different areas of our hospital, not only the nephrology department, but vascular surgery and cardiothoracic surgery. Thank you.